Okay, perfect. So hi everyone, my name is Irina and welcome to our May edition of Research Reels. So we'll take you a bit through the introduction first before we get into the seminar. I'll try to be quick with this. So briefly, I'd like to introduce IMPART to you as always. So we're a national research team headquartered at Dalhousie Medicine, New Brunswick. And as I always say, although we are headquartered there, we encompass 45 academic and clinical partners across 8 universities all across Canada. And Research Reels is a monthly seminar series we created to try to improve networking and collaboration amongst IMPART members. And hopefully this will enhance research opportunities for trainees and researchers across Canada. As well, if you know someone who you think would be a great speaker for Research Reels, stay tuned to our post-webinar survey, where there will be an opportunity for you to nominate a future speaker. So IMPART is really present on all these different social media platforms, as you can see, Facebook, Instagram. So feel free to follow us there to keep up with some of our new opportunities, openings, some of our publications as well. And if you do ever miss one of these seminars, we do upload them to our YouTube channel, which is just Research IMPART. As you can see, we have some of these uploaded already. So take a look, see if there's any other sessions that you enjoy. So now I'll go into introducing today's speaker, who is Dr. Danielle Bouchard, an associate professor in the Faculty of Kinesiology at UNB-Fredericton, so that's University of New Brunswick. She is an undergrad in physical education from the Université de Moncton, an MSc from the Université du Québec à Trois-Rivières in exercise science, and a PhD from the Université de Sherbrooke in gerontology. She completed 2 postdoctoral trainings, one in epidemiology at Queen's University, and the second in endocrinology at the Université de Sherbrooke. The main focus of her research relates to clinical exercise physiology to evaluate the impact of regular exercise on chronic conditions, especially in people living with obesity and older adults. She is internationally known in physical activity and aging, and she just published a book as a sole editor for Human Kinetics. She has published about 80 peer-reviewed publications, mainly in physical activity and aging, and has presented her work all across the world. She's on the Lifestyle Committee for the Canadian Longitudinal Study on Aging, on the Journal of Aging and Physical Activity editorial board, and was involved with the Canadian Frailty Network to develop guidelines for physical activity for frail adults. So without further ado, I will now pass over the floor to Dr. Bouchard, who will present her research.
Thank you. Thank you for having me. When you list everything that I did, I feel like I did something. Always good. Do you see my screen now?
Yes, it's just at the PowerPoint. Perfect.
That works? So
yes.
Okay, perfect. So I decided to talk to you about a project that would happen, I guess, in the last year, and keep in mind that this was done before COVID, so things could have been different now. So what I'm going to talk to you about is a randomized trial that we've done in New Brunswick. And the goal was to stand older adults that live in nursing homes. So to put you in context, we're talking about long-term care. We're talking about people that are assisted 24 hours a day. So I want to start off with what is, we've been like talking a lot about, I don't know if you see my mouse, but like moderate vigorous activity has been like what we've been focusing on as exercise scientists in the last 100 years, where we know the benefits of doing moderate to vigorous activity. However, with the new technologies being available, with the workforce changing so much, we spend a lot of time sitting, and in nursing home that's even more the case, and all demographic included, older adults will be the one sitting most of the time or more time during the day. We did look, when you look at the definition itself, sedentary behavior, mostly sitting, is when you don't spend a lot of energy and then you are sort of consuming less oxygen when you're sitting, reclining, or in a lying position. That's kind of the official definition of like sedentary behavior. So when you look into like how much time people, older adults, for our case here, are sitting, 80% of your day, if you're an older adult living in the community, you'll be like either sitting or meeting that definition, sitting, laying down, or reclining position. That goes up to like 83% if you're living in a nursing home, but you still are mobile, so you can walk. And then it goes up to 93% when you are mostly in a wheelchair and need help to transfer from one position to the other. And obviously, if you're completely dependent, meaning that you're in a lift, you'll be like spending most of your time considered being sedentary. So we did a pilot study a couple of years ago, trying to figure out like, would it be possible to stand people, so reduce or break down the sedentary behavior in a long-term care. We recruited people in a public nursing home, and we got to take like whoever was interested at that point. There was a lot of reluctance of standing older adults in long-term care because the family are pretty inanimate that they'd like them to sit more, so they have with the perception that you have less risk of falls. So we went there, asked people to stand with us, assisted, for 5 days a week, every day of the week. And then, it was Monday, Wednesday, Friday, Monday, every 2 days we were show up. So 4 times a week. And we were standing them in 10-minute bouts. And what we learned there is like how many people actually show up. 24 people came, which was pretty good. We also like look into like, if you do it in the morning, afternoon, or evening, when do they show up more? So they seem to be more interested in doing this type of activity in the morning. So when you plot that on the graph, you see that morning sessions were more attended. And as I said, like we went Monday, Wednesday, Friday, Sunday, and what we found is there's differences as well with the weekend not being interested of like doing such a thing. We would perceive as young people that a Sunday is the same as a Monday for them. But we heard a lot of like, well, Sunday is church day and we're not working and you're getting us to work when you're standing. So we learned that with this pilot study. It led us to like 3 different questions that we answered with a randomized trial. First, we asked like, is standing 100 minutes per week would improve gait speed? And gait speed being like a good predictor of hospitalization, institutionalization, and also a length of stay when you're hospitalized. Is standing 100 minutes per week a reduced risk of falls? And we also looked into like, is it accepted by a resident to stand like this as an intervention? So how did we answer our questions? We, as I said, like 100 minutes a week. We had like a group doing that. Monday to Friday, we would come in and we would go like 20 minutes a day, mainly in the morning, if they were able to do 20 minutes, or split it into 2 sessions, but we avoided the evening and avoided the weekend, as we learned in our pilot study. The control group, the staff was going to see them, but not standing with them. Like, so what we were doing with them when they were standing was like talking about the news, what was going on during Halloween, during Christmas, talking about like what those are research students that research assistants that were students, talking about like why technology is that great for them compared to like what they don't know about what cell phone, when they wonder why kids are always having their cell phone, well, they don't have one. And so intergeneration discussion, and that happened at both control intervention. How we collected data, like we collected data with different ways, and just for the sake of this presentation, I'm just going to show you like what we did for the main outcome that I showed you. So first we did walking speed. So we got people to do a 10-meter standardized walking speed test, where we want to know how fast they walk when they're walking at their typical pace. They could use assisted device if they needed. And then we also asked the homes for giving us access to their fall registry. So anytime that someone falls in a long-term care, they'd be registered or they'd be reported. And finally, we had semi-structured interview to know how acceptable this type of program is in long-term care. Okay, so a bit of the results. There's many more results, and all those projects or those research questions are in process of being published. Some of them are submitted, and two of them are submitted. One of them is on the way. So you'll have more information if you need more. So control versus intervention, no difference in characteristics in terms of frailty. Oh, that's an error here for severe frailty. That would be like severe frailty would be the proportion of people that were between 7 and 9 on a scale of 1 to 9. So the more the proportion is higher, the more frail people were. Even though there's seemed to be a difference, it was not statistically different, but there are some descriptive that you can see that are different. When you look at gait speed, which was our main outcome, it's considered as being really low. So even though like you're seeing a difference with more faster walking speed in the control group, it was about similar, no significant difference. And if you look at standing minutes, so that's the number of minutes that people stand in their day. So it's about an hour and a half for both groups that they would be in a different position than sitting or laying down. So not a lot of standing to start off with. This is the attendance. It's more so like to present what happened during the trial. So the line, blue line is a control group and the red line is the intervention group. So although we were offering older adults in those long-term care to stand for 100 minutes, the average was 42 minutes. So not as attended as we would like. And then I can't say that how much we worked to get them to stand that much. But you need to keep in mind that this population has a lot of heterogeneity in terms of like their day-to-day activity from one day to the other. Could be like super willing to do it, and the next day, because of different issues, they might not even remember that in the study. So, or they could be like hospitalized for a couple of weeks, or there's many things happening. It's not only a question of like wanted to be there. And in terms of gait speed, if you concentrate your attention on the red boxes, and this is on the left side, you have like the gait speed for our intervention group, and you can see that didn't change over time, and the control group neither, which was not surprising, but we would have expected, or we had hypothesized that if you were to stand 100 minutes a week, it could transfer into like more function and tested here in this case with walking speed, but no difference. So we are here trying to figure out why. Many reasons for that we develop in the paper, but that's what we found. In terms of falls, it was expected again that if these people would gain strength, gain some functional abilities, that could translate into like having less falls. So if you concentrate your attention on the red box, we asked the home to give us 6 months prior. So like prior to, like if you look at the first two columns, prior to the intervention group seemed to like fall less, and that's reported as fall per person in the program. So like that would have been expected to stay at least that way, but during the program they fell more, and it's not directly related to our trial, because we do know that once, like when we were with them, like physically with them, there was no falls besides one. So there was one fall in the whole intervention, and then we see like an increased rate of falls. So that also is interesting. Why is that happening? Why do we get more falls from 0.73 to 1.1 during the trial? Because it was not with us. Some will speculate that they got pretty confident with their standing and they would stand without us. However, when you go back to the home the next day and they don't remember who you are, for some of them, it's kind of hard to believe that they would remember how standing is so easy now, or able to do it, and then they would do it. I'm not too sure about that, but that's speculation for now. 6 months after we left the house, so we're not there anymore, the intervention group falls more. 12 months after we're gone, we still have the reports on like how much falling these people have, and even, I mean, it's not changing. So basically, the results show that the intervention group fell more often than the control group, which is inverse of what we expected. And if you look at the stats that goes with it, it's pretty alarming, because it is significantly different. And not only it's significantly different, it's 2 times more. So the people in our intervention did fall 2 times more 1 year after we went. So with our exercise physiology background, we're like alarmed to see this, and like, oh, that should be good. Why is it not good? So if there's anything with this project relates to falls, it brought more question than it brought answers. But it might not be related to the intervention itself. It's just an association. We don't know if it's because of the intervention. The only thing we can report right now is the people that are there did fall more, but we don't have the context. And one interesting thing that we have with long-term care is falls is such a big issue and has so many consequences that we rely on staff to report falls. And although they report falls, when you look at the reason why, like the reason why people would have, like the person would have fall, it usually is unknown situation, unwitnessed situation. So no one kind of want to, it might be some of that, but we don't know the context. So that my point here is, yes, they felt more, but we don't know the context. So we can't say, make a connection with the intervention, but it's still there. Acceptability now, like, so when we go and do interviews with people that are cognitively able to answer questions, we did use the acceptability framework, and we looked into like, how is the intervention attractive for them? And what they reported is that a lot about the fact that we had external students coming in. That was really important. Some of the things that they said, they got me up out of my chair, felt very safe. People were there to support me. If you are happy, standing doesn't take so long. Like I got to get it, and it was good. It was some limitation with the intervention itself in terms of like perception. Someone said like, I'm a 91-year-old. I gave up with this. Like, I don't need to do this to myself. It seemed like pretty hard for her to do. Participation value, like we talked about like how it got them more mobile. So we also got people saying like, when my loved one picked me up for a visit, I'm able to go in the car more easily, type of thing that they reported. The intervention comprehension, so like we live in a world in nursing home where not everybody like will understand exactly what's going on. So like they would say like, one said that the second one, like participant 7 said like, well, when I stand up with them, I think I'm going to make, they're trying to make me taller, which is not maybe what we're after. But so like sometimes some issues with that in this setting. Competing activities, I mean, nursing home are not full of activities, but they do have some things going on. So we would have like, well, I can't stand because I do have like to go play crib. Intervention impact, we had some quotes coming over with this. I noticed that my standing improved, my leg got stronger. So there's a perception that they did improve, even though we haven't seen it. I presented today like the gait speed, but any functional capacity that we looked at didn't seem to improve significantly in the intervention group. And level of confidence in terms of fear, I feel very comfortable with myself. I didn't feel that I was at risk of falling. That's the type of thing that came in. So in terms of like perception, more positive on that side. So what we found really, to summarize, is that gait speed was not improved for participants in the intervention group compared to the control. The incident of fall was not reduced for participants in the intervention 12 months after being part of the program. And despite some limitation, the intervention was well accepted and there was perceived benefits. So at the end of the day, like you ask yourself, what are the next steps? This has been done for at least a year now with everything being collected. And we're still wondering, what is the next step? Like, can you go out and then promote this? Can you like skip on knowledge transfer and say like, we know sitting is not good, we should stand. Here's how you can do it. We haven't seen any benefits clearly. So what are the next steps? We're still wondering about it. We're still trying to figure out why. And there's not a lot of literature in long-term care and standing intervention. So we're kind of a pioneer in that sense. So I'm hoping to get some more answers by others doing similar things. So we can actually move to the next step, and how can we actually break out the sedentary in nursing home and have some benefits, because it'd be hard to like promote this as it is with the findings that we had. So I'll thank you for your time, and I'll take some questions about the program or anything that we do in Cell Lab that you were aware of.
Thank you so much, Dr. Bouchard. That was definitely very interesting. So I'm sure there's definitely some questions to be asked. So I'm going to stop recording and we can get into the Q&A portion.